adjunctive therapy, and then we'll also look at how to follow up patients with community-acquired pneumonia. Sorry. So these are the members that we are working with in our group. So our outline, we'll be looking at oxygen therapy. We'll look at adjunctive therapies. We'll look at resolving pneumonia, and then we'll finish with non-resolving pneumonia. So let's start with the first part, which is oxygen therapy or oxygen supplementation in pneumonia. So under this part, we are basically trying to find out, basically in community-acquired pneumonia, in what scenarios do you really want to use non-invasive, high-flow nasal oxygen? So before we look at the main study question, we'll start by looking at the oxygen devices. We have an oxygen concentrator, we have compressed oxygen cylinders, we also have liquid oxygen. Then for the delivery systems, we have a low-flow delivery system and the high-flow delivery system. Although today we'll be focusing more on the high flow, but we just mentioned a few on the examples of the low flow, like nasal cannula, that gives 1 to 6 liters per minute, that increases FiO2 by 4%. And then simple face mask is another example. We have transtracheal oxygen catheter and the non-rebreather mask. So the high flow delivery systems, on the other hand, we have the rebreather mask, we have the Venturi mask, and then we have high flow nasal cannula, which you can see can flow up to 60 liters per minute. And if FiO2 can go up to 100%. So the main part in oxygen therapy, we were supposed to find out whether in hypoxemic patients, can you use non-invasive high flow oxygen to avoid intubation and reduce mortality. So non-invasive high flow oxygen, just from the name, less invasive, it preserves airway reflexes as compared to intubation. There's reduced risk of ventilator-associated complications like ventilator-associated pneumonia. Then there's improved patient comfort, and also there's that potential to avoid intubation when you use high flow, non-invasive high flow oxygen. So in what scenarios in community-acquired pneumonia do you want to use non-invasive high-flow nasal oxygen? The first group of patients are those with mild and moderate hypoxemia. That mild hypoxemia is between 86 and 90%, and moderate between 81 and 85%. So of SpO2. So those patients, you can actually give an invasive high-flow nasal oxygen. The second category is when you're avoiding intubation in selected cases, like patients with tolerable hypoxemia, like the ones I've mentioned. When you're in a setting where there is adequate monitoring and resources, then also when there is a reasonable chance of improvement in your patient from your clinical judgment, and also when the patient has stable hemodynamics. Additionally, patient preference or refusal of intubation, especially patients who are conscious, alert, and they're also able to cooperate. So those cases of patients are examples of scenarios where you'll use non-invasive high-flow nasal oxygen. Then it's also important to note that you can measure, oxygen measuring in pneumonia can be done in some ways. For example, we have arterial oxygen pressure and oxygen saturation, which is SpO2. Remember, SpO2 is non-invasive compared to arterial oxygen pressure, which is invasive. It can also be continuously done. The monitoring is continuous, and then it's also easy to use. The arterial oxygen pressures are important, especially in ARDS. So for oxygen therapy, it's important to note that one, non-invasive ventilation is easy to administer as compared to intubation. And then there are fewer complications. Remember, ventilation associated pneumonia from intubation, shorter hospital stay. We've said the patients, there's improved patient comfort, and as well, you're able to avoid intubation. The second part is the adjunctive therapies that can be used in community-acquired pneumonia. So under the adjunctive therapies, we were supposed to check which patients qualify for the use of steroids, in which patients can we use anticoagulants, for example, both parenteral and oral anticoagulants, and then which patients require airway clearance techniques. So let's start with steroids as adjunctive therapy, therapy in community-acquired pneumonia. So the first part, who qualifies for steroids? Patients with community-acquired pneumonia. What are the indications? One, patients with severe community-acquired pneumonia. When we continue, we'll see the benefits of steroids. So we'll see how they benefit patients with severe community-acquired pneumonia benefit from steroids. Then we have patients with signs of systemic inflammation. For example, patients with persistent fever, markedly elevated inflammatory markers like CRP and ProCal, and where there's evidence of organ dysfunction. And then patients at risk of ARDS, for example, the old or the elderly patients, patients with chronic lung diseases, and the immunocompromised. And then also patients with asthma or other chronic lung conditions. So how long are you going to give the steroid therapy? We have the short course and prolonged course, where a short course you give the steroids for 3 to 7 days, and the prolonged course for more than 7 days. Again, the factors that determine its response to treatment and underlying medical conditions, those are the factors that will help in considering or determining the duration of therapy. The steroids of use, for example, you can use dexamethasone and prednisolone from the researches that we found. So what is the role of steroids in community-acquired pneumonia? Just as just as from the normal roles of steroids, one is the anti-inflammatory effects, where steroids, they are able to stop inflammation. Remember, in community-acquired pneumonia, there is inflammation, and especially when it becomes severe, there's a lot of inflammation. There are a lot of inflammatory markers coming in, and this worsening of the inflammation can lead to damage of the lung parenchyma. Therefore, this can be stopped with steroids. Then we have reduction in cytokine storm. Again, in community-acquired pneumonia, there is in community-acquired pneumonia, especially in severe community-acquired pneumonia, we can have cytokine storm, where the immune system will release an overwhelming amount of cytokines. So this response can be harmful, and therefore we need steroids to modulate the immune system and prevent the severity of cytokine storm. Then steroids also improve lung function. They also lead to a shortened hospital stay. Studies have suggested that patients, especially those who have severe community-acquired pneumonia, who are given steroids, had shorter hospital stays compared to the ones who were not on steroid therapy. There is also reduced risk of respiratory failure. Remember, progression of community-acquired pneumonia can lead to acute respiratory distress syndrome. This can be severe and sometimes can lead to mortality. So to stop inflammation with steroids, you can curb respiratory failure, and this can lead to patient survival. Then also improved radiological findings. We'll see towards the end of the presentation some of the radiological, when the radiological findings are resolved. So with use of steroids, studies have shown that there'll be faster resolution of the radiological infiltrates that were seen earlier on, and this indicates quick recovery and this lower risk of complications. So steroids can be used in community-acquired pneumonia for those indications that we have listed. The second adjunctive therapy is anticoagulants. Under anticoagulants, we're going to look at which patients benefit from anticoagulation. And if it is anticoagulation, do we want to use parenteral or we want to give oral anticoagulants? So first of all, you realize that patients who are admitted can be given parenteral anticoagulants such as heparin. But if a patient will require long-term anticoagulation from clinical judgment and with other underlying conditions, or if from the admission, they will require a longer dose of anticoagulation, they can be discharged on oral anticoagulants like rivaroxaban, which again does not require a lot of monitoring as compared to discharging the patient on, for example, warfarin. So which patients require anticoagulants? One, these are patients who have community-acquired pneumonia and they have been admitted in ICU. Sometimes these patients will take long or longer durations in ICU, and this immobility can, together with other risk factors that you may not have evaluated, they can be at a risk of clot formation. So patients who are admitted in ICU can be given anticoagulants. Then patients with severe community-acquired pneumonia, again, this we've tried to separate this from the first. Some people will feel like already a patient in ICU has severe, but we've tried to bring this here because we are trying to bring out the facts that severe community-acquired pneumonia, there is that hyperinflammatory state that can activate coagulation system. Remember, not all patients who have community-acquired pneumonia, all of them will be admitted to ICU, again, depending on ICU admission protocols. So again, these patients will benefit from anticoagulation. And then now individualized risk assessment. The patient in front of you, the risk factors, the comorbidities. Does that patient require anticoagulants? Then now, what is the role of anticoagulants in community-acquired pneumonia? One, they prevent venous thromboembolism in patients with severe community-acquired pneumonia. For example, as I've said, patients in ICU. Anticoagulants also modulate the coagulation cascade in severe infections where there's a state of hyperinflammation. These have also explained. Then reduction in microvascular thrombosis, again in severe community-acquired pneumonia, which can lead to development of ARDS. And also anticoagulants prevent progression to ARDS. The other adjunctive therapy, we've looked at steroids and we've looked at anticoagulants. The other adjunctive therapy is activated protein C. So activated protein C first is just a natural anticoagulant protein that plays a role in regulating the coagulation cascade and modulating inflammatory response. So from multiple researches that we have the references down, and also there's this research here that we brought out, the recombinant human activated protein C worldwide evaluation in severe sepsis. This was a trial that was done in 2001, and then it was followed by the PROES shock. Both of them did not find any role of activating protein C in community-acquired pneumonia. Also, there are other studies that have been done, and there is limited use or limited evidence of the use of activated protein C in community-acquired pneumonia. In fact, activated protein C has been associated with the risk of bleeding, including intracranial bleeding, which is a significant concern. So from our research, activated protein C use there is limited evidence of its use. So up to now, we've covered oxygen therapy and we've looked at adjunctive therapies. We are moving to another part, airway clearance techniques. So airway clearance techniques are methods that are used to help clear mucus, secretions, or other obstructions from the airways. So that is basically what we'll be looking at during this part. These are methods used to help clear mucus, secretions, or other obstructions from the airways. Now, sometimes during or when in chest infections, there's a buildup of mucus in the respiratory system. And this mucus has to find its way out, or they have to be removed depending on the patient that you have in front of you. So you realize that in some conditions, especially chronic lung conditions like bronchiectasis and cystic fibrosis, there is a lot of mucus that accumulates in the airway, and therefore there are airway clearance techniques that have always been used to clear away mucus and those secretions from the airway. So what are these methods? We have chest physiotherapy. So chest physiotherapy, it just involves that rhythmic clapping or percussion on the chest together with the back. This loosens and mobilizes mucus, and therefore it can be removed out. Postural drainage. Postural drainage, you put the patient in specific positions, like for example, left lateral position, and this can help drainage of mucus. And this method is dependent on gravity. Breathing exercises. Breathing exercises are techniques like we have deep breathing, we have huffling, we have forced expiratory techniques. These again just help to force mucus up the airway, and then the mucus goes out. We have another method, the positive expiratory pressure or PEP devices. These devices, they just create back pressure during exhalation, and this keeps the airway open and mobilize mucus. Then we have the high frequency oscillation, high frequency chest wall oscillation. We have flutter valve, nebulized hypertonic saline is also another method, and we have intrapulmonary percussive pressure. So these are some of the airway clearance techniques. So we'll be asking ourselves, we are talking about community-acquired pneumonia. Who qualifies for airway clearance techniques in community-acquired pneumonia? We are all aware that in community-acquired pneumonia, airway clearance techniques, again, are not typically considered standard treatment. Remember, airway clearance techniques, as I've said, is reserved for individuals with chronic conditions that lead to buildup of mucus or secretions in the airway. Like, for example, I've mentioned bronchiectasis and cystic fibrosis. However, in severe cases of community-acquired pneumonia, particularly if there's a significant amount of mucus or secretions buildup, or if the patient maybe has a pre-existing lung condition, or even if the healthcare providers find the methods fit, then airway clearance techniques can be part of the treatment plan. So patients who qualify for airway clearance techniques, again, if there's significant amount of mucus or secretions buildup, if the patient has pre-existing lung condition, and if the healthcare providers consider the method fit. So that is on airway clearance techniques. So we are almost coming to the end. So at this part, we want to start looking at follow-up of community-acquired pneumonia. So under follow-up for community-acquired pneumonia, we look at resolving pneumonia and non-resolving pneumonia. Or you can say patients who are improving and patients who are not improving. What do we do? If a patient is improving, how do we follow them up? When should we stop antibiotics? When do you want to discharge? What are the improving markers, both if they're in ICU or in the ward? When do you want them to come back to the clinic after discharge? If the patients are not improving or you are dealing with non-resolving pneumonia, what next? How do you detect this is non-resolving pneumonia? When do we change antibiotics? What lab tests are of interest? When do we want to repeat imaging? Who do we consult? And so on. So how do we follow up improving patients? So improving patients, again, we want to look at the clinical signs of improvement. But again, remember, you have been with the patient, and what will make you judge that the patient is improving? You have to do your symptoms review. You have to do a physical exam, both general and systemic examination, and evaluate that your initial findings or the initial findings reported in the file are now either resolving or they are not there. You have to reevaluate the vitals again in the general exam. Sometimes you may require a chest x-ray, so chest x-ray if needed, lab tests, and then we have medications review for patients who are improving, and then again, of course, medical education and advice. So what are the signs of clinical improvement? So when we started earlier on in part one, you saw some of the key things that indicate a patient could be having pneumonia. So a patient will be improving when the patient is, the temperature is now coming below 38 and coming to the normal temperature range. The lab biomarkers are also coming within normal range. Stable immune response. The vitals are also stabilizing, or we can say the vitals are coming to the normal range. Then the lab parameters, again, we want to check lab parameters like procalcitonin, CRP, ESR. But remember, again, from some of the studies you are seeing, there is less reliance on white cell count in ESR because they have lower sensitivity and specificity compared to inflammatory markers, CRP, and procalcitonin. So again, the lab markers, you can do them, but remember again, CRP and procalcitonin will help you a lot, especially procalcitonin, because it's mostly we are dealing with bacterial pneumonia. Then when do we want to de-escalate antibiotics? So you found out your cultures are now negative. The patient has received IV antibiotics for now more than 48 hours. And they are clinically, they are improving, and also from your laboratory tests, they are improving. You can de-escalate them from IV antibiotics to oral medication. When do you want to stop the antibiotics? Duration of empiric antibiotics is 5 days for community-acquired pneumonia and 7 days for hospital-acquired pneumonia. So 5 days for CFP. When do we want to discharge the patient? Just as I've mentioned, the vitals have come to the normal range. Lung function oxygenation at its best, negative blood culture, white blood cell count is below 12, comorbid illness have been stabilized, you can discharge the patient. Then we are also supposed to talk about vaccination for prevention of pneumonia during this part. So the vaccines that are used, we have pneumococcal vaccine and influenza vaccine. So these vaccines can be administered to the elderly and the immunosuppressed patients. We are now turning to the last part of the presentation, that is non-resolving pneumonia. So as when we began this part, I described that, again, non-resolving pneumonia is a situation where a person's symptoms and even the radiological findings of pneumonia persist or even they worsen despite appropriate antibiotic treatment. So how do you say that this is non-resolving pneumonia? You have the patient is on appropriate antibiotic treatment, but the symptoms, radiological findings, and other parameters important in diagnosis are in fact persisting or worsening. What are some of the causes of non-resolving pneumonia? We'll be looking at some of them. I'll mention some of them because things are everywhere, but they include incomplete antibiotic treatment. Yeah, like you can see, inappropriate antimicrobial therapy, drug resistance, or drug-resistant bacteria. We have complications or abscess formation. That is another one. And then underlying lung conditions, patients with underlying lung conditions. And then immunocompromised states, patients who have HIV and AIDS, patients who are on chemotherapy, aspiration pneumonia, and also patients who have uncommon or atypical pathogens like Mycobacterium, nocardia, actinomyces. Yeah, these ones are causes. So non-resolving pneumonia can be again caused by age, comorbidities that I've mentioned, severity, nature of the infectious agent, and the others that I've mentioned. This is also explaining the same. So what is the rate of resolution of physical and lab abnormalities? So both the physical, those are the findings on physical examination, and of course laboratory from the lab. So for example, fever, between 2 to 4 days, the patient fever should have resolved. The vitals, tachycardia and hypotension within 2 days. Cough 4 to 9 days, crackles 3 to 6 days, leukocytosis 3 to 4 days, CRP 1 to 3 days, and then chest X-ray abnormalities about 4 to 12 weeks. So a patient is considered to have responded if the fever declines within 72 hours, the temperature normalizes within 5 days, and then respiratory signs such as tachypnea and the others that we had been told in part 1, they all return to normal. So how do we approach non-resolving pneumonia? So you assess for risk factors that I've mentioned, for example, age, patient has comorbidities, severity of the pneumonia, specific pathogen. Once you have done that, is the rate of resolution appropriate? If yes, continue with your therapy and observe the patient. Monitor the patient closely. Is the rate of resolution appropriate? If no, repeat history taking for clues, and also try to find out things like unusual pathogens and other non-infectious causes. In this case, you can do chest CT and you can also do laboratory tests. If the diagnosis becomes apparent, then you modify your treatment as per your new findings. If you get a parenchymal lesion whose diagnosis is apparent, you modify your treatment tailored to your current findings. If the parenchymal lesion diagnosis is not apparent, you can opt to do bronchoscopy with bronchoalveolar lavage plus transbronchial biopsy, or you can do a CT-guided transthoracic FNA plus or minus core biopsy. If you have a diagnosis that is apparent, you modify your treatment as per what you get. If the diagnosis is not apparent, you can consider surgical lung biopsy or video-assisted thoracoscopic surgery. If you have done your chest CT and lab, and now you have mediastinal or peribronchial lymphadenopathy, if you have an apparent diagnosis, if the diagnosis is not apparent, you can do again bronchoscopy with endobronchial ultrasound guided FNA or bronchoscopy with transbronchial biopsy. If the diagnosis is not apparent, you consider surgical biopsy. If it is apparent, just modify your treatment. But again, if you get mediastinal or peribronchial lymphadenopathy and you have an apparent diagnosis, again, you modify your treatment. So this is just a chart or to just again show some of the things that you can do. This is again explaining the same thing that I've just explained from your history, physical exam, the tests you can do. You find a patient with persistent infection. Are they not improving? Is pleural infusion coming in? Again, you can easily follow the CT I've talked about, and again, bronchoscopy. So finally, community-acquired pneumonia can present, if not well taken care of, you can have complications like lung abscess, empyema. You have respiratory failure. You can have death, confusion, uremia, hypotension, and thromboembolic phenomenon. So this is just another chart, although I know you are not able to see it clearly, but what it's describing is just that for non-resolving pneumonia, what I've just explained, are those diseases mimicking pneumonia. So look at your differentials for infections, inflammation, we have injury, or even neoplasia. Is it the right drug? You could be saying that you're dealing with non-resolving pneumonia, but you're not using the right drug. You're not following the guidelines. You could be dealing with non-resolving pneumonia, but the organism maybe is resistant, or it is one of the atypical organisms. So again, these are factors that we have already explained. So in summary, we've talked about those 4: oxygen therapy, adjunctive therapies, resolving pneumonia, and non-resolving pneumonia. And these are just some of the references that we had. And that's the end of our presentation.
Okay, thank you, Dr. Okor, for that presentation. Maybe just one or two things that I think might require clarification. That was on the use of adjunctive steroids, because I think maybe it didn't come out very clearly, but there are specific places where it's indicated. And then the use of anticoagulants. Maybe we'll say it's not anticoagulation, but it's more of a prophylaxis of DVT. for all patients. So not anticoagulation doses of the anticoagulants. So maybe on the part of steroids, maybe I can ask Dr. Nyale to comment on where you would use steroids in pneumonia, and any other comments that you may have, Dr. Nyale, before we go to the Q&A. Dr. Nyale is a chest physician based at Kenyatta National Hospital.
Hello. Thank you, Dr. Juma. Now for steroids, we mainly use them when there's a lot of inflammation and the infection is not, and somebody is not in sepsis. So you've got to make sure that it's not, the person doesn't have overwhelming infection, and inflammation is a major thing. So you're really looking to look at somebody with severe inflammatory response syndrome. Most commonly, it's seen with viral pneumonias more than bacterial, but there are also bacterial pneumonias that can lead to this. So you need to be very prudent when you're using them. Usually, we don't use very high doses because high doses do lower the immunity, making control of the infection worse. We use low doses and usually for a short time. So that's when we use them. For instance, people like in COVID pneumonia, people with influenza, viral pneumonias, commonly people can give that. Also, if people have got reactive airways diseases due to the pneumonia, reactive airways disease means they will have a bit of shortness of breath and a bit of wheezing. In that kind of scenario, then you can give a low dose. Let's keep the doses of steroids very short. Most people do less than 5 days. In fact, some people do 3 days. Long doses really are not justified unless you have another cause of immunosuppression or you're needing immunosuppression or steroid supplementation, like in the case if you get people who have their adrenals affected by pneumonias, more common in TB, but can also happen with other viral pneumonias. So usually these will be very sick patients. Most of them will have hypotension and a lot of inflammation, and make sure that the infection is not overwhelming. Thank you.
Thank you, Dr. Nyale. Maybe just another question that I have, maybe to direct it to Dr. Nyale. I think it was interesting for the patient, when you're presenting on the patient who is not responding, from the guidelines, usually in the past when we were treating pneumonia, we used to have first line therapy, second line, and sometimes people even used to do like third line. But from the guidelines, it's like you just have the first treatment which you select, so the empiric therapy, and then for deteriorating patient, a patient where the pneumonia is not resolving, you'd reassess the patient. I don't know what your views are on that.
Well, we can have a generic guideline that basically says what is the first line and what is second line. Although people now are going much more to looking for evidence as opposed to having a generic guideline like that. So most people will tell you, look for risks of MDR bug and then know the flora of your hospital or the resistance in your hospital so that you have a good chance of treating it the first time. If it doesn't go, most of the guidelines now are tending towards not going into a blind second line, but actually testing so that you have more evidence of what you're going to use as an alternate. But no harm, if you're in Kenyatta, probably we should be tested because we are at the National Hospital. Probably I would say if you are at a district hospital, yes, maybe you can be able to get a second line, which basically means we've looked at our patients with pneumonia and seen what are the most common bugs that actually might not be covered by the first line.
Okay, thank you for that clarification. So I'll just go to the Q&A. So there are several questions there. So someone is asking whether steroids and anticoagulants can be given simultaneously as adjuvant therapy for community-acquired pneumonia.
The short answer is yes. In COVID, you did that. You gave anticoagulation and you gave steroids.
Yeah. Okay. So the next question, someone is asking about mucolytics, whether they have a role, for example, mucosolvant in mucus clearance.
Mucus and mucokinetics has really been a very dicey field. There are those who think mucus plays a role on its own. There are those that think mucus doesn't play a role on its own. So you have to see on which side of the divide. But they're usually those mucus active diseases. And most of these are people who have had things like bronchiectasis before and they get a pneumonia, or they have other lung damages that actually damage the mucus excretion apparatus. Either the airways have been destroyed or the villi have been destroyed, and these people are not able to get their mucus out. That's when such things come into play. So they're not for everyone. Most people will agree if people have prior damage and bronchiectasis, or they're known to have COPD, or they're known to have any other cause of lung damage, then it's easier to give those therapies. For people who are just having a fast pneumonia, haven't had other lung damages before, so this pneumonia is not coming on top of a damaged airway, some people will tend to hold it. But then there comes a question. There are those people who get what we call persistent bacterial bronchitis, whereby they have a low-grade bacterial persistence in the airway, and they always have mucus production. And most of them usually will tend to eventually develop bronchiectasis. In those kind of patients as well, mucus, removing mucus does give an advantage.
Okay, thank you. So there's a question here. How do you know a patient is suffering from typical pneumonia and not atypical?
Well, you see, these terms came out of how patients of pneumonia present. The typical way that people present is having a lobar kind of pneumonia. They have fevers and they have symptoms that basically you can say he has got cough, he's got fever, he's got chest pain. Those are the typical symptoms, and they have a typical picture, which is really over consolidation. Now, there's some people who have a mixture of these symptoms that are not prominent and a picture on X-ray that does not really completely follow what is typically seen. Those were the ones that were called atypical. And most of these were thought to be caused by bacteria or other organisms that don't give good consolidation or formation of consolidation in the lung. But since we now know that it's erroneous to call this atypical, a pneumonia is a pneumonia, okay? So we still use the name atypical to refer to atypical bacterial or atypical organisms, not atypical pneumonia. Now, the atypical organisms means organisms that don't commonly cause pneumonia. If you are looking, you'll have the top 10, or the ones that account for 80% of pneumonias. All the other that account for 20% of the pneumonias are rare and are called atypical. They are not typical causes. That's what it basically means.
Okay, so the next question, someone is asking whether it's strictly cast in stone for one to treat pneumonia for 5 days and stop, and hospital-acquired pneumonia for 7 days and stop when the patient has had an incomplete response. I think they're asking, is there room for prolonging the therapy a little bit?
I think this was dealt with by group 2, but the answer is that no, it's not cast in stone. Okay, there are two competing principles here. Is that first, if you've killed a bacteria, you've killed a bug, yeah, you don't need to kill it twice. Okay, that speaks to early discontinuation of antimicrobials. Because if you've already killed it, you don't need to kill it a second time. So why do you want to continue antibiotics for a long time? On the other is if you've not completely killed the bacteria, especially if you have time-dependent killers, okay? If it's not completely dead, okay, probably the time taken for it to die is not yet. Would giving a prolonged treatment give you better elimination of the bacteria? And sometimes the answer is yes, because sometimes you're looking at time above time to be able to kill, especially in time-dependent killers. So the time is not cast in stone. But the studies in pneumonia show that if you give a 7-day therapy or you give a 14-day therapy, the mortality is not changed. There's no difference in mortality. There was a small trend towards recurrences with the shorter regime, which was not significant. So basically, most people prefer short whenever you can. You really have to justify using a longer-term therapy. So longer-term therapies are for people who probably have a lot of mucus, so your antibiotics are not going to be able to get into the mucus very well to be able to eliminate the bacteria, or people who have persistent bacterial bronchitis. In that kind of patient, then you can. There are few causes of pneumonia that will give longer therapy, and it is known. If probably you find a methicillin-resistant Staph aureus, then it's justified that you give 2 weeks, because shorter therapies tend to have more recurrences. There's also been the debate if you have an MDR Pseudomonas, okay, in a patient who has a pneumonia. Then in that kind of scenario, people show if you give a longer therapy, you get a better resolution than a shorter therapy. But in most of the other bugs, short is better.
Thank you. So I think by that discussion, you've answered 2 of those questions, because people have posted questions on MDR, Pseudomonas duration of treatment, as well as Acinetobacter. There's a question here on cough syrups, whether they add any value in the treatment of pneumonia. I think you've talked about mucolytics already.
But the other usual cough syrups in pneumonia, they don't help cut short the duration. They make patients more comfortable. So comfortability, if it's an issue, person is coughing a lot or is getting a lot of chest pains because of the cough, then you can soothe it a little, but it won't change the duration. Now, that's different from acute respiratory infections, because some studies, especially in pediatrics, some of them done locally in Aga Khan and I'm not sure which other hospital, show that these honey-based syrup do actually lead to a resolution of the ARIs, acute respiratory infections, by at least a day earlier than when they're given, than if you don't give them. And the issue was they thought probably the honey might have some anti-inflammatory effect. But usually cough syrups don't help in pneumonia. In a good bacterial pneumonia, they don't. Mucolytics are only for people who have mucus problems, previous damage, bronchiectasis. Okay. So this issue about ARIs, most of them are usually going to be viral. And basically, so the short of it is that cough syrups don't add any value. They don't change mortality. They don't lower length of stay in hospital. They don't bring down the treatment duration. So basically, it's more or less like a placebo trying to deal with a symptom, which is basically trying to reduce the cough. So in most of these places, unless somebody is really, really in trouble because of the symptom, the best thing is to avoid the cough syrup.
Okay, thank you. So I think there are 2 more questions on there. One maybe should have been, one is about complications. Maybe start with that one. So they're asking, do patients with a moderate pleural effusion without dyspnea, maybe I don't know if they mean a parapneumonic effusion, can that effusion, once it's a moderate size, can it resolve with antibiotics only, or we don't need to tap that patient?
Now, if you have a parapneumonic effusion and it is small, it can actually resolve on its own. Especially if people are young, there are quite a number of people who we treat effusions without necessarily tapping them. And basically, sometimes tapping them leads to estrogenic infection and actually empyemas in this patient. So we try and discourage, unless it's a huge effusion or you think you have loculations, that you need to break or put something there to be able to break the loculation, or if it's causing actual respiratory embarrassment. So if you have it causing respiratory embarrassment, then that's when you can actually be able to tap. For small ones, just giving antibiotics alone leads to resolution of the pneumonia and reabsorption of the pleural fluid. So you might not need to tap it. And even in developed countries, even when we are dealing with effusions, usually if you go to the pleural clinic, the first day is actually people just take a syringe and just take a sample to see. They don't usually remove all the fluid. So this hurry of removing fluid, unless it's really causing a shift of the mediastinum and respiratory embarrassment, is usually not necessary.
Okay. There's a question here, which is more about treatment. They're asking your thoughts on nebulized amikacin in pneumonia, whether you have any experience. We didn't cover this yesterday. I had not seen this, come across this anywhere.
Okay. Nebulized antibiotics are things that come in and out of fashion. Okay. The purpose of giving a nebulized antibiotic is so that you can get high local concentrations of the antibiotic. Okay. The trouble has been the best way of delivering it has been very problematic. And you don't get a consistent deposition of the nebulized molecule in the airway where you'd want it. So most of us think sometimes it ends up in the major airway, and that's not where your pneumonia is sitting. Some people think if you use a good mesh nebulizer, then you can get smaller particles, and you might get a good delivery in there. We've used it in the past, even in Kenyatta ICU, we've used it. But our use has actually been limited to people who have multi-drug resistant bags, who don't have any other options for treatment. We've gotten people in the ICU who are totally resistant to everything, including colistin. And in such kind of patients, that's when we actually nebulize that, especially if they're in renal failure, to try and get a local control. Sometimes we've gotten away, sometimes we've not. But by and large, it's one of the most evolving spaces. The promise is that if we get a good delivery mechanism, would probably be best treating pneumonias by nebulized antibiotics. But you might still require a mixture of two, especially in pneumonia, because not all of the disease is in the airway. And absorption of some of these antibiotics when you nebulize them is quite small. So they don't solve your bacteremia, because most of the pneumonias have a bacteremic phase as well. You won't solve that. And if there's any other metastatic infection from the pneumonia, it's hard to solve it with inhaled antibiotics. So we've used it. It has given us mixed results, even in Kenyatta. We don't routinely recommend it. You can try when you are pushed between the wall and the hard place. Best to try with a mesh nebulizer so that you get small particulate matter, but you'll also need to have a systemic antibiotic for other systemic foci of infection. And we are watching that space. So far, the only one that has been more accepted in terms of inhaled antibiotic has actually been tobramycin inhaler. There's actually a tobramycin inhaler for people with the cystic fibrosis or bronchiectasis. In such kind of people, then you can have the inhaler with tobramycin. Colistin, we've also nebulized it, mixed responses. Sometimes when you actually nebulize colistin, you actually end up with signs of bronchospasms and bronchoconstriction, including wheezing. So you'll probably need to nebulize them with a bronchodilator before you use them. So we've used it. It's given us mixed reaction. I don't think it is the first line. I don't think it's the prime thing. I think it is something to have if you are pushed between the rock and the hard place, and not to regularly use it.
Okay, thank you. So I think there's one question here, but I don't know if it's relevant to this presentation. Someone is asking about, is there any improvement when you use nebulized antifibrinolytics in hemoptysis?
I don't understand the question. Using inhaled?
Inhaled antifibrinolytics in hemoptysis. So maybe it's not, doesn't make sense.
Okay.
Yeah.
Well, I'm not sure what he wants to achieve, yeah? But by and large, you see the coagulation system is not in the airway, so you hardly get anything. Unless you're either going to put a big dose and flush it in at the bleeding vessel, or you give it IV. Nebulizing it might not get you there. So even when you're doing bronchoscopies and people are bleeding, we actually use a flash of the medicine to try and get the bleeding under control. And sometimes we don't use fibrinolytics. All what we do, we use is most of the time adrenaline, but I know those things have all been tried, including a flash of tranexamic. But most of the time you're better off with it intravenous. So this is not, in pneumonia, you will see hemoptysis and you don't need to treat it unless it's massive, because the hemoptysis is part of the red hepatization of a pneumonia. It's part of the normal nature and process of a pneumonia. So if he's talking about hemoptysis in pneumonia, it is something that's expected to occur early on. Remember, after consolidation and red hepatization, during red hepatization, you can have people having a little hemoptysis. It is not something that you need to treat on its own. All what you need to do is concentrate on treating the pneumonia, which is the primary cause. Those other things will resolve.
Thank you. I think that was the last question. There's just a lot of queries about the CPD points, which I think the ICT team will take a note of. So I think it's 1 minute to 8 o'clock. So maybe we can have parting shots from Dr. Okot and then from Dr. Nyale. I don't know if Dr. Okot. Dr. Okot? Yeah.
Yes, thank you so much for the attendance. I hope the presentation was clear and you were able to get the important parts of the presentation today. So I want to thank you all for the attendance. If there are any queries or there is anything, maybe I've seen other people asking for the slides. Probably we can share with the ICT team, then the slides will you'll then get them from there. Otherwise, thank you so much, guys, and have a good evening.
Thank you. Dr. Nyale, anything additional?
Well, it's very encouraging that you've done this good job, Dr. Phoebe. I think you deserve a clap. I think our own homegrown pneumonia guidelines is long overdue. We should not just be relying on international guidelines when we've got experts in Kenya. And it's good that you took the lead, and it's very encouraging. Even for the other disease areas, I think the experts should come together and make a local guideline that says what we want and what we want to do and where we want to take this. So, and I'm also happy and humbled that almost 700 people could join this pneumonia discussion, which is very encouraging that people still are interested in making a difference in this space. So I want to thank you. And I think pneumonia is an evolving place. So this guideline is just a guide. Your clinical knowledge is still important, and it should be a living document because things will change. New antibiotics will come in, new tests will come in, and then we can keep on adding them and regularly updating our guideline. Thank you very much.
Okay, thank you, Dr. Nyale, for that. Thank you to all the participants for attending. Thank you, Dr. Okot, for that presentation. It was clear. proceeding from here, now we'll go and put all three together and see whether we can come up with an algorithm or use at our institution. And going forward, maybe we'll have a presentation on that in future. So thank you all again for joining us, and enjoy your weekend. And bye, you can log off.